and how they're arranged and everything. Okay, so one, identify the following. What's one? This should be easy. I'm assuming you guys know it. Sos major. I know you guys know it. Yeah. Okay, what about two? Minor. طيب. Three. Where's three? Three is right here. As soon as you see this, iliacus, exactly. Four. Four is here. I actually forgot what four is exactly pointing. Nope. Wait, sorry. Yeah, it's four. I was looking at 14. My bad. Four, yes. Quadratus lumborum. Okay. Five. Five is lateral wall muscles. It's already revealed. But six. Where's, yeah, six. Exactly, your kidney. Seven. Yep. Let me just reveal them. Okay. Eight. Where's eight? Eight's right here. So follow the path. What is eight? If you go up, you can see how it joins another structure here. Okay, I think someone said something, but I couldn't hear. Your voice is low. Do you want to repeat? So this is an artery. Does anyone know what the artery is called? Okay, yeah, it's the common iliac. I think this is after the bifurcation, actually, because it bifurcates here. Because that means, yeah, it bifurcates here. So this is the external iliac. Okay, and you can see the ureter crosses over it. It crosses over the bifurcation. So the internal iliac is actually here, external here, and this is the common. Okay. 10. Where's 10? 10 is right here, right behind the kidney. You've got 10 and 11. What are these structures? These are important posterior relations to the kidney. Yes, iliohypogastric and what's the one below it? Ilioinguinal. Yeah, you can kind of remember, no, this is ilioinguinal because it goes down here near the iliacus as well. Okay. And yeah, you've got 12, which is the lateral cutaneous nerve of the thigh. You can see how it goes it's the longest and it goes laterally all the way down. The femoral nerve, 13, it's right here. It goes down along with the X towards the leg, basically. Then you've got the genitofemoral, which is 14. It's right here. You can see how the genitofemoral, it's also long and it comes from L1 and L2, if I'm not mistaken. We'll go over them now in a bit. So, what is this? Okay, so identify the labeled structures and their nerve supply. So let's start with A. Can anyone identify A? So you've got the vertebrae right here, and you've got a muscle right beside it.
So major.
Exactly. B.
Iliacus.
Yes. C.
So major.
Yep. And D. It's another muscle that's posterior.
Quadratus.
Exactly, yeah, quadratus. So you can differentiate the quadratus from the iliacus by, iliacus, it's right on the iliac spine. Okay, quadratus is a bit more up, it's a bit more superior. Okay, and it's behind the sos major at one point. Okay, it's more medial, basically.
Okay. Do we need to know the nerve supply?
I think because I saw it once, if you understand what I mean, but that's why it's good to know. And a sos major is mainly by L1, L3. The iliacus is supplied by the femoral nerve, and femoral nerve, you should definitely know its source, which is L2 to L4. And quadratus lumborum is from the anterior rami of T12 and L1, L4. So try to memorize them if you can, Yani.
Okay.
Okay.
So,
طيب. Now you have the lumbar plexus. So let's form it together. So you have, first thing, the lumbar plexus forms within what muscle?
psoas major muscle.
Yeah. Then it divides and branches into lateral branches and anterior branches. The lateral branches start with the subcostal. Then there are nerves that come out from the L1 root only. What are they? Two nerves come out from the L1.
Hypogastric and ilioinguinal.
Exactly. And then the L2 and L3. L2 and L3 join to form one long nerve. It's a
femoral nerve.
no. These are lateral branches. So think of something that will go laterally. Yes, lateral cutaneous nerve of the thigh. So yeah, this is L2, L3, okay? What's a special thing about lateral cutaneous nerve of the thigh? Can you guys think of a clinical significance, like, or a scenario that's linked to this nerve that was provided? I think they mentioned it in the lab before. Anything special about it, or how it can get injured, for example, a common scenario of how it can get injured.
I think
compressive. When
Yeah.
it's compressed.
Yeah, so when you wear very tight dress or very tight clothing, okay, so that's when it can get compressed, and then you can feel paresthesia because of it. Okay,
Clown syndrome. Yeah.
I'm not sure if that's what it's called, but if that's what they told you, then great. But I'm honestly not sure what it's called.
It has
Someone
another name, but I forgot it.
Merglia prosthetic, someone suggested that. I don't know if that's what they told you. But yeah, it's important to remember in how does it get injured when you wear very tight clothing, because it's like it travels laterally, so it can easily come compressed when you're wearing tight clothing. Type L2, L4. So L2, L4 roots give rise to two nerves, femoral and obturator, exactly. And then you got the lumbosacral trunk. Then the anterior nerves, L1 and L2, they form an anterior branch that goes down and meet genitofemoral, exactly. And we can see it here. You can see how you got, this is a subcostal. Here, this is L1. It forms iliohypogastric and ilioinguinal. Then L1 and L2, they join and form the genitofemoral. Okay. Then you've got, this is L2, right? So L2 and L3 and L4, they all join to form the femoral. And they join again to form the obturator. Is someone speaking? I think I don't know if you're asking, William, can you unmuted yourself accidentally? But yeah, if you have a question, let me know. Okay.
What about the lumbosacral?
Lumbosacral, if I'm not mistaken, I don't think it was labeled here. Yeah, it's not labeled here, but it should be joining with the sacral plexus, Yani. Here it is, sorry. Hey, this, and I'm pretty sure it joins with the sacral plexus as well. That's why
L4 and 5, right? L4 and 5.
Again, I'm not sure, but if you're sure of that information, okay, but I'll make sure, Yani.
Okay.
But these are the ones that I saw again in the resources, Yani, so that's why I put them. Okay. Okay. So we've got them. Okay, now we have another one. This is what I said, the tight clothing, how it compresses the lateral cutaneous. Okay, so we have these labeled nerves. These images were in or this one at least was in your file, so you guys should be a bit familiar with it. Does anyone know what A is? Which nerve is A?
Is it the subcostal?
No, it's not the subcostal. Subcostal would be more...
Iliohypogastric.
Yeah, it's the iliohypogastric, if I'm not mistaken. Yep. Then we have B.
Ilioinguinal?
No, it's longer and goes all the way.
It's the lateral cutaneous nerve.
Yes. See, you can kind of see the roots. Comes from L2, L3, and L4.
1, 2, 3, 4. Not sure. Femoral or obturator?
Femoral. So you can tell it's the femoral because it's the thick one. Femoral, it's the one that goes down and supplies your leg. So it's the thick one, okay?
Okay.
And the next one, same sources, but it's more medial.
The obturator.
Yep. And here you can see branch from L4 for the lumbosacral. This is the... Then finally, you have a long, thin one that's very interior and medial. This is what?
I don't know.
It's the genitofemoral, okay? It's long, thin, and it's more anterior or medial, okay?
Okay.
Here, it's more, it's not shown how it's going down. It's just cut in this section. It's this one. Okay. Yeah, you can see here labelings again. Ileo, hypogastric, ilioinguinal. These are the exact same ones that we went over, okay? Now, this is a very important one. You guys need to memorize by heart how the aorta looks like, okay? So it's very good to keep seeing pictures of the aorta and its branches so that you have it memorized. Trust me, you'll need it all the way up to 5th year. So you have A, what is this? This branch right here.
Right renal artery.
Sorry?
The right renal artery.
Not quite, no. This is more superior.
Suprarenal. Right suprarenal.
Suprarenal would not be this thick.
Not
It's for an
sure.
important organ on the right side. So try to imagine the aorta. So this is the beginning of the aorta, okay?
The phrenic. The right phrenic. Or the inferior lung.
No.
I don't
Wait,
know.
I want to see if someone inferior phrenic. No. Can anyone? Okay, do you guys know the aorta, abdominal aorta? What's the first major branch it has? Because there's 3 main branches that they have, if you guys remember.
Celiac trunk.
There's a
Celiac
celiac trunk, exactly, yeah. And the celiac trunk, out of it comes what? On the right side. Someone said it in the comments, but yeah, I just want to see if you guys
Common
can know.
hepatic.
Yeah, so this would be the hepatic, okay? Because it's the
Mhm.
right side, okay?
Okay.
It's the thick artery. That means the left side would be what? This one.
Superior mesenteric. Yes,
No,
the superior mesenteric.
on the same level as the hepatic. No, not the left gastric. This is, as you can see, it's like more coiled and like it's going to directly to an organ that's here on their left side. Yes, it's a splenic. It's a splenic artery. Okay. So opposite, think of it this way: liver on this side, spleen is on this side. They're like polar opposites. Okay. So you've got the splenic artery, then you've got the common hepatic artery. Okay.
Okay.
So then you go down. Superior mesenteric isn't really shown here, if I'm not mistaken. Okay, so you got the common hepatic, right renal. Like, oh, amzah, sorry. B, okay, so B is what you guys saw it basically. But then you've got a right one and a left one. So this would be the
Right and left renal artery.
exactly, okay. You C,
Right common iliac.
yes. طيب, E is left renal. We have F,
Abdominal
know.
aorta.
yep, and then G.
I don't know.
Internal iliac.
Yes, internal iliac. Okay, so superior mesenteric would be above, between the celiac and the renal arteries. It would be in this area. And inferior mesenteric would be here. If I'm not mistaken, this would be the inferior mesenteric. Okay. Now, what's the level of the aortic abdominal aorta bifurcation? This level.
T12.
Bifurcation.
This one, L4.
L4, yeah, but it enters at T12, just like you said. Okay. So now again, A. Can anyone identify A?
Iliac trunk.
Celiac trunk, exactly. Then B.
Superior mesenteric.
Yes. Does anyone know a syndrome where
Nutcracker syndrome.
exactly, yes, superior mesenteric, where it compresses the renal vein,
Yes,
right?
the left,
The
yeah.
left renal vein. What else does it compress, طيب, do you know?
The left testicular vein.
The what?
The left testicular vein. I guess.
That's true. Yeah, it would, if it's in a male, yeah, but there's another structure here that's it can also compress. Besides, it's not a vascular structure. Does anyone know?
Not sure. Maybe the bulk of the left kidney.
No, it's not even renal. It's not a renal structure. It's a GI structure, and it runs under the superior mesenteric. It's just a bonus question for you guys. So it's the duodenum, okay? So the duodenum can actually get obstructed by the superior mesenteric artery as well. That's why you should also think of, they'd have duodenal obstruction and would have vomiting and signs of obstruction, basically, because of this syndrome as well. So it doesn't just affect the left renal vein, okay?
Okay.
Type. Now C.
Is it the aorta?
Yes.
Aorta.
Yeah, abdominal aorta. D.
Inferior mesenteric.
Not quite. It's paired. It's a paired artery. So it has left and a right one. Inferior mesenteric is only a single one. And it would be thicker as well. So you've got two arteries here. What are they? Can anyone in the chat guess? They branch off of the aorta directly. And they're two thin arteries that travel down. Yes, the gonadal arteries. Okay, so this would be the left and right gonadal arteries. Type. Then E is inferior mesenteric. Yes. Okay, so E is inferior mesenteric is not paired. So you'd see it alone and it's like thick and it's usually more on the left side, just like the superior mesenteric. You'd see it kind of going towards this side. Okay. Then F, this is what we saw. Here, splenic artery. Okay.
Splenic.
Yes, you can see how it's usually coiled and it goes directly to the spleen. Opposite to it would be the common hepatic. Like, then G.
The I think the inferior suprarenal.
Suprarenal, exactly. It's the suprarenal vein. Okay, not artery. This is a vein.
Yes, drains in the
H.
left renal vein. So
What about H? This is the renal left renal vein as well.
yes.
And J.
The testicular vein.
Or ovarian vein.
Yes.
So gonadal vein, basically. Yeah.
You know.
Okay. Type. Let's see. So you've got the inferior vena cava. The inferior vena cava is formed at what vertebral level? Does anyone know what? Yes, L5. And it enters the thorax at
Then.
T8. Exactly.
Okay.
Abdominal aorta, you mentioned this previously, I think. You said it starts at the level T12 and bifurcates at the level L4. Okay. Type. Now the left gonadal vein, it drains into what?
Left renal vein.
It drains into the left renal vein.
Renal vein.
Yes. While the right gonadal drains where?
IVC.
Exactly. Type. What's the clinical significance? Can anyone tell me? A clinical why this is important to know, طيب. Okay. So do you guys know a condition called varicocele? Did you guys take it yet? Yep.
Yes.
So what is varicocele? Can someone explain?
It's when there is a lot of blood, because sometimes it's because of renal hypertension. A lot of blood is pooling into the gonadal vessels, and because there is nowhere for the blood to drain into. So, and it's mostly on the left side, so the blood will pool into the testicles, and that will lead to varicocele.
Exactly. So it's usually caused by an obstruction to the drainage of the gonads, right? And usually, if let's say someone has a tumor, this is when it becomes worrisome. If someone has a tumor in their renal, let's go back here. Let me show you. If they have a tumor right here, a renal tumor that's compressing the left renal vein, that's, as you said, that will block the drainage of the gonads. So the testes or the ovaries, they won't be properly drained because of the tumor compressing the left renal vein. So this will cause, in a male, it will cause their scrotum to swell on the left side. That's why if any male has a left scrotal swelling and it feels soft, like a bag of worms. This tells us it's a varicocele. The next thing we should do, especially if he's an old man, is an ultrasound of the kidney, okay, of the abdomen, to check if he has a renal tumor, okay, because that could be the cause of the varicocele, okay. But as you said, there are many things that can cause it, yani. Come on, it's basically any block or obstruction in the drainage of the gonads, okay? So this is important to remember because they like asking about it, yani. Type, what's another vein that drains into the left renal vein while its right counterpart drains directly into the IVC? We know that
suprarenal.
Yeah, suprarenal, exactly. Okay, and this diagram kind of shows it as well. You guys can look at it. You can see here in the left suprarenal, sometimes it drains into the inferior phrenic directly, and sometimes it drains directly into the left renal. But the idea is, overall, it does not drain into the IVC. It drains first into the left renal, then goes to the IVC. And same thing with the gonadal. Right, anatomy of the kidney. So we know the kidney is a retroperitoneal organ, as well as the ureter. Another thing we know is that it's divided into the superior poles and inferior poles, as well as superior and inferior segments. But how do we know if this picture is if this is the anterior surface or the posterior surface of the kidney? How can you know?
Anterior will be the vein and posterior will be the pelvis.
Okay, so how will you know if it's an anterior kidney? If the vein is what? Anterior, and the ureter or your pelvis is posterior, right? So this would be the anterior kidney, and this would be the posterior surface of the kidney, because you can see exactly. So in the posterior kidney, the ureter is anterior, but in the anterior surface, the renal vein is anterior. This is they can get you a picture of a cadaver kidney, yani, no, with showing you the hilum and everything, and they could ask you, is this the anterior surface or posterior? That's a possible question, come on. Now the anterior relations of the kidney, okay? Right, let's start with this one. What's this?
Is it the suprarenal?
Yep. So suprarenal, it covers mainly the superior medial portion of the kidney. This is the suprarenal as well, okay? The right and the left. What about here? What's on the kidney on this side? It's the superolateral part of the kidney. What covers it?
No, it's not the pancreas. Pancreas is medial.
Pancreas would be here. This is the left kidney. So what do we have on the left side here?
Spleen.
Exactly.
Yes, spleen.
Okay.
Spleen and stomach.
Or stomach. Spleen and stomach, exactly. Both of them, because they're very close to each other. Type. What about inferolaterally on the left kidney?
Large intestine.
Yes, exactly. Or left colic flexure. Then same inferior medially.
Jejunum.
Exactly. And as he mentioned, the pancreas, tail of pancreas right here. Okay, so this is in the left kidney. Now the right kidney, the medial part of the right kidney. What's here?
The second part of the duodenum.
Sah. Okay. And what about here? Inferomedially?
Intestines.
Yep. It
Small
mirrors
intestine.
this. In small intestine.
Jejunum both.
Exactly. The jejunum in both. So they kind of mirror each other. Okay. You can remember it like that. In both inferomedially is jejunum. Hina pancreas in the middle. Hina duodenum. For both suprarenal. Okay. Then the lateral parts, hina spleen, stomach. So what's directly opposite to the spleen and the stomach on the right side?
The liver.
Exactly. And what about here?
Large intestine.
Yeah, the right colic flexure, which is the large intestine. It's okay. So they kind of mirror each other. You can memorize it like that. So let's see. This just shows the anterior relations again. It's another diagram. Like I said, seeing multiple pictures of the kidneys in various pictures, it really helps with visualizing and memorizing. So that's why I put them. Hina, I made the things that are pink. Why are these things pink? Do you guys know? Can you guess? Why are they different? The inferior medial surface and superior lateral surface of the right kidney. Why is it pink? because it is what? It's covered by something.
The fascia.
Peritoneum.
Yes, it's covered by peritoneum. Okay, it has peritoneum. That's why it's pink. Okay, same thing with
Okay.
the left kidney. Okay. But now this is the posterior surface of the kidney, which is also very important. So can anyone tell me what this rib is? What's the number of this rib?
11th,
11th and
12th.
Okay. Then what lies here on the green area? Posterior to the kidney.
The psoas major muscle.
Not quite. Yeah, someone said it in the comments, diaphragm. Okay, because you can tell diaphragm, it extends from min فوق لتحت, so it's near the ribs, so you can remember it that way. So here
Yes.
we have diaphragm. It forms like a cross. Its cross forms like this. Okay, then
Okay.
we have hina, the most medial.
Psoas major.
Exactly, because it's near the vertebra. So imagine the vertebra is here and the psoas major is beside it. So it's covering the medial parts of the kidney. Then after the psoas major, what's beside it?
Quadratus.
Yes, lumborum. Then the most lateral. It
The
extends to the,
transverse.
yes,
Transverse
transverse
abdominis.
abdomen. Yep. It extends laterally around the lateral walls of the abdomen. So yeah. Okay, now what are the two nerves that run posterior to the kidney? We mentioned them earlier. There are two important.
L1 and subcostal.
I think, yeah, subcostal, I'm not sure. But yeah, actually, إلا subcostal probably. But في two, L1 is the two nerves, اللي هما ilioinguinal and iliohypogastric, okay?
Okay.
Yeah, they're the very important ones, okay? And you've also have the subcostal nerves and vessels here as well.
Okay.
Okay. Now, clinical significance, okay? So behind the kidney, there's costodiaphragmatic recess, right? So what's a possible clinical scenario or what's the clinical significance of this recess? What can happen when you're doing surgery on the kidney, for
You're
example?
approaching
the
the kidney
most-
posteriorly.
Sorry? One of you guys was saying something.
Go ahead. When you're approaching the kidneys from the posterior side, you might end up with pneumothorax.
Exactly, yeah. Pneumothorax. Someone said it in the comments, come on. Pneumothorax. That's why you need to be careful when you're approaching the kidney posteriorly. Okay, you can't approach it min فوق. Usually they approach it from a lower angle. Okay, so they don't cause pneumothorax. Now the layers of the kidney, very important. Come on. The yellow is kidney, that's obvious, but what's the blue? What is it called?
The fibrous layer.
Yeah, or capsule or renal capsule. Green, what's the green?
Perirenal fat.
Yes, or perinephric fat. Then what's the red?
The renal fascia.
Yep. And the pink, you know,
Pararenal fat, I guess.
peri fat. Yes, exactly. Good job. Now,
I think it has like clinical
yeah.
significance too.
Yeah, it does. I wanted to ask you guys if they told you, because Anna, I didn't find it in your head. I found multiple things, but I don't know which one they wanted for you guys to know. So
They
do you
just
know
said that, like when you have like an inflammation in the kidney and it spreads outside, I don't know what was the name of the clinic or significant.
Okay. Yeah, see, the one I found is that, no, I think it was more related to the perinephric fat, how it's related to atherosclerotic diseases and when you have more of this visceral fat, you're more likely to have cardiovascular disease. But that's what I know with the perinephric fat. A pararenal, you said, they mentioned about spread of infection, basically, or inflammation.
Yes, inflammation from the perinephric fat.
From the perinephric fat. Okay, yeah. So it's from the perinephric fat as well. Okay, خلاص تمام. Because I saw that before. They mentioned it once, I think, in previous. Yeah. طيب. Now match the following with the letters. Okay, so where is the renal pelvis? Which letter? D. Exactly. Okay. Major. What about the major calyx?
C. No. I
Yes.
guess it's C. C.
It is C. Okay. Minor calyx type.
Minor is E.
E. Yes. Renal cortex.
A.
Medulla.
B.
B.
Yes.
Yeah. Column. Renal column.
H.
E. Yes. H. And pyramid. Renal pyramid. G. Exactly. And fibrous capsule.
I.
Finally, the ureter.
Letter F.
F. Exactly. Okay, this image, memorize it by heart because you're probably going to get something like it, either diagram or cadaver. Okay. And know the functions يعني of whatever they mentioned, the structures they mentioned. طيب, can anyone tell me what the arrows are pointing at here? And if this
من هان لبكره ما هعرف اجاوب هاي.
ما هتعرف Does anyone know? طيب.
renal capsule.
Not quite. يعني this is the renal capsule. بس it's pointing at it هنا. The arrows are pointing something here. This black space. Interesting. Fat is bright on ultrasound. Okay, it's not black. Fluid is actually black. So whenever you see black on ultrasound, you should know that it's fluid. Okay, it can be blood, it can be serous fluid, it can be المهم إنه it's fluid. Okay, whenever you see black, it's fluid. So there's fluid here between the kidney and another structure. It's like a big structure here.
Is it the liver?
Renal pouch.
Yes. So this is the liver. This is the liver, and this is the right kidney. This space is called what?
Hepatorenal pouch.
Yes. Hepatorenal. Do you know another name for it?
Morrison's pouch.
Morrison's pouch. Exactly. Right. Which is so Morrison's pouch, it's the potential space between the kidney and the liver. Does anyone know what that means? Like, can anyone explain the clinical significance of this?
It's the deepest space when the patient is lying supine. So whenever there is leakage of any blood or fluid while doing surgery, it's most likely to be in that space.
Exactly. So fluid basically accumulates in this space when they're lying supine. So normally, it's as they call it a potential space. يعني normally it doesn't have any fluid. يعني normally you should not see this. Okay, there should be no black here. Okay, but when someone has fluid in their abdomen or blood or anything, it would show up on ultrasound when they're supine, as you mentioned. Okay, so it's basically a sign of free fluid in the abdomen when fluid fills up in the Morrison's pouch. Okay, so normally it does not have fluid. It's closed. You don't see it, but when there's fluid, you will see it. Okay.
Is it related to the renal system?
What do you mean it's related to the renal system?
يعني يكون في مشكلة في الرينال.
مو شرط ممكن يكون مثلا if someone has internal bleeding, like if there's if abdominal aorta is ruptured, or if there's any artery is ruptured in the abdomen, it can cause free fluid there. It's basically can become if there's any because it's a retroperitoneal, it's going to be retroperitoneal area, if you get me. For anything that causes free fluid in that area, from rupture of either the aorta or the veins, it can cause fluid in that area. And they usually detect it أصلاً in the ER. Usually when someone comes into the ER, where he has he's very hypotensive, his blood pressure is low, he appears to be in shock, they do something called the FAST, which is the I forgot what the F stands for, but I think it's fast ultrasound, abdominal sonography, something like this, where they have to do immediate ultrasound for the abdomen to look if there's any internal bleeding. So this is something, this scan you would see in the ER quite often, because they're looking if there's any internal bleeding. And what they do is they look at the Morrison's pouch. They see if there's any fluid there. This would indicate, okay, this guy has bleeding, we should take him to the OR right now. Okay, so that's what it.
It's called Morrison's pouch and بس هيك نعرف إنه
Yeah, this
space is
pouch, this space right here is called Morrison's pouch, and it's usually not seen. يعني it's usually closed. You don't see this black line بالultrasound لما you do the ultrasound, because normally it's not filled with fluid. That's why they call it potential space. The other name, as suggested by someone else, it's the hepatorenal pouch or hepatorenal recess. Okay. But the idea is, like I said, it's a potential space. Normally it does not have fluid, but if there's any internal bleeding or any fluid in the abdomen, you will see it on ultrasound.
So the accumulation of the fluid in the peritoneum will راح تكون هنا.
Yeah, accumulation of fluid in the Morrison's pouch or the recess. When they're supine, remember, it will show when they're supine, not when they're standing. Okay. طيب. Now, next question is, where are the glomeruli found? In A or B?
In A.
Yep. Why?
Because A is the cortex.
Exactly. So deeper would be the medulla, outer is cortex. So A is where the glomeruli are found. Right. Now onto the ureter anatomy and blood supply. So how is the ureter formed? It begins with the renal pelvis. Then you have the what?
Uretero-pelvic junction.
Exactly. Then the ureter. Then the ureter descends along the anterior surface of what? It descends down along the anterior surface of a structure.
Sauce major.
Yes.
Not sure. Yes, I guess sauce major.
It's sauce major. Then it goes down and enters the pelvic cavity by crossing the pelvic brim and what?
Bifurcation of the aorta. Of common iliac.
Common iliac, exactly. Then it travels down the lateral walls. At the level of ischial spine, it turns anteromedially. It pierces the bladder in what manner? How does it pierce the bladder, basically? Does it enter vertically, horizontally, obliquely? Exactly. Right, Muhib. Okay. And what's the significance of this? Why does it enter obliquely, Yani? Does anyone know why?
عشان ما يصير في obstruction.
Actually, عشان ما يصير في reflux or regurgitation. So لما urine goes down and goes into the bladder, it forms, when it enters this way, it forms a one-way valve. So that when the urine accumulates in the bladder, it does not go back. That's why it enters the bladder in an oblique way. Okay?
Okay, to prevent backflow.
Exactly. Okay, by forming a one-way valve. And you can see here the major calyx, the renal pelvis. Here you have the uretero-pelvic junction. Then the ureter goes down. Okay, here along the surface of the sauce major. Then it enters the pelvic cavity by crossing the bifurcation of the common iliac arteries, as we mentioned. And it goes down the lateral walls of the pelvic cavity, then travels anteromedially and goes into the bladder. Okay. So, هلا we'll see كمان Okay. Blood supply. Does anyone know blood supply? The ureter is divided into the abdominal and pelvic ureter. The proximal segment, it's supplied by what artery? Think of what's close to it, yani. What's the closest artery to the proximal segment of the ureter?
Renal artery?
Yeah, so it's the closest, so it gets supplied by the renal artery. Like then the middle segment after that. Exactly, gonadal, and some branches from the
common iliac.
Abdominal aorta, actually. Okay, and you'll see now the image when I show you. Okay. Type distal segment. Does anyone know what the distal segment is supplied by?
Inferior vesicle.
Inferior and superior vesicle. Those are the main supplies, yani. So here, you'll see how the ureter beginning, it's by the renal artery. Then here it's the gonadal and some direct branches from the abdominal aorta. Okay. Then when it enters the cavity, it has many supplies, but the main supplies are superior and inferior vesical arteries.
Okay.
Okay, so now the important anatomic relations of the ureter, okay? First, let's fill in the blanks, then we'll answer this. The ureter runs anterior to what? We mentioned one of them, but في another thing that we didn't mention. So the ureter, what's posterior to it? There are two things that are posterior to it that you need to know.
Genitofemoral nerve.
Yes, and the other one?
Psoas major.
Exactly. طيب, what runs anterior to the abdominal?
Could you repeat, please? First part.
So ureter runs anterior to the psoas major muscle that we mentioned من شوية, and the genitofemoral. So genitofemoral nerve is posterior to the ureter. Okay?
Okay.
Then what runs anterior to the abdominal ureter? So these two are posterior. What is anterior to the ureter?
Gonadal vein.
Gonadal vessels. Okay. طيب, now name another structure that runs above the ureter and its clinical significance. Can anyone, do you know any other structure that runs above the ureter? Uterine artery, exactly, Sajid. طيب, do you know the clinical significance? Why is this important to know? Why do surgeons need to know this?
Because during hysterectomy, the surgeons need to be careful not to cut the ureter with the uterine artery.
Because usually when they do us on hysterectomy, they have to ligate or clamp the uterine artery, so they can accidentally clamp both the uterine and the ureter. So if they do that, usually what you see is that the patient, after the surgery, they present with urinary retention. And they're not able to urinate, and they can have even ureter rupture, or hydroureter, hydronephrosis, or coagulation. So it's a very serious thing. So that's why you would suspect it in people with history of hysterectomy, okay? And this is the diagram. So can you identify the underlying structures on the diagram? So where's the psoas muscle? What number? I think by the end of this session, you should have the psoas muscle memorized. يعني من
3.
كتر ما. Exactly, 3. Genitofemoral.
What is the genitofemoral?
Yes, which number?
Should be posterior. I think number 6.
Exactly, so 6. You can see how it runs posteriorly. طيب. Then the gonadal vessels. It's kind of obvious, يعني.
Anterior.
Yeah, so it's just this. You can see how they're twisted around each other.
Yes.
Okay.
Number 5.
طيب. And yeah, this is what we said. Okay. طيب. Now identify the labeled structures. What's A?
The minor.
Yes. B.
Major. مش شايف فرق صراحة. Ureter.
Yeah, ureter. And D.
Bladder.
Okay.
Pelvic.
And E. Pelvic. Yeah, uretero-pelvic junction. Or the renal pelvis, sorry, not junction. It's the pelvis.
Right.
Okay. Now describe what the diagram shows. Can anyone tell me what the diagram is showing? So not urogram, not diagram.
Enlargement of the right kidney. This is posterior view, right? Enlargement of the left kidney.
Your first, it's the right kidney.
Right?
No. Yeah. Enlargement of what? So you have dilation of the calyceal system and the ureter, right? So they say hydroureter. Okay. They call it hydroureter. And what else do you notice in the, can you notice anything else? Compare this with this. Stagger.
The ureters are bigger. Enlargement of the ureter.
Yeah, we said that, but what's يعني هنا it's continuous, صح? You can see the contrast, it's moving continuously. هنا إيش في? There's a defect, obstruction. Yeah. So you can see there's a filling defect. So this is most likely a stone. It's not a staghorn stone, actually. هنا, this appears like a staghorn, but it's actually just dilation of the calyceal system because of the obstruction, okay? The staghorn would be more كده bright, if I'm not mistaken. طيب. Now what are the typical sites of obstruction by the renal stones? There's 3 sites that you guys should know.
Ureter pelvic.
Yes.
Pelvic brim.
So uretero-pelvic, yes. Then pelvic rim, which is like around this area.
And the urinary bladder.
What's the junction called? Do you know?
Yeah.
Does anyone else know the junction? What the junction is called? The last point. Uretero-vesical, exactly. Okay. Or vesico-ureter. Okay. طيب. Now identify the labeled structures هنا. What's A?
Urachus.
Okay, that's yeah, it's a remnant of urachus. What's the other name for it? Do you know?
Median umbilical ligament.
Median umbilicus. So it stretches from hina, from the top of the bladder to the umbilicus. That's why if someone presents with yellowish discoloration coming out from their umbilicus, you would think of patent urachus. You know, they have patent urachus. Okay. Okay.
So it's the umbilical ligament.
Yeah, this is median umbilical ligament. That's what it's called, which is a
Okay.
derivative of urachus. Okay. And usually it should be obliterated. يعني the urachus becomes obliterated and fibrous like this. It's like a fibrous structure. It's a ligament. But in some people, when they can have patent urachus, where basically it's like a tunnel from the bladder all the way to the umbilicus, and they would come to you with urination from their umbilicus, like there would be yellow urine coming out of their umbilicus, and they wouldn't know basically.
It's called the urethral fistula, I guess.
Yeah, exactly. It would be a fistula at that time. You can have fistula, you can have urachus cyst, you can have urachal, I think there's another thing, come on, there are 3 conditions. But yeah, just know it's from the median umbilical ligament. Type, that's A. What's B?
Is it?
So Mhm.
No, I'm not sure. Well,
So you have the median umbilical ligament. This would be the,
lateral.
exactly, lateral umbilical ligament. You have it on both sides. Not to be confused with the ureter, which is more posterior and comes down.
ما كنت أحكي له.
Yeah, أنا حسيت. Okay, so ureter is coming, it's more posterior. طيب, what about C?
عند المسل.
Yeah, what is it?
Distro, مش عارف.
The trusser, yeah.
Trusser.
Okay. D, what were these things called?
Rugae.
Yep. E,
The openings of the
yeah,
bladder.
urethral openings or the orifice, if you want, whatever you want to. G, what is this?
Trigon.
The smooth part.
This is the trigon, exactly, the smooth part. And F,
The prostate.
Prostate.
yep. And what's the derivative of G, which is the trigon, we said?
Seminal vesicle and vasodifference, I guess.
لا, the embryological derivative, يعني from what structure did it originate from? Embryology.
Mesoderm.
Yep, mesoderm, specifically mesonephric duct, okay? What about the rest of the bladder? Do you guys know?
It's endoderm, I guess.
Yeah, do you know the structure? The exact structure?
No.
Does anyone know where the bladder was derived from? Splanchnic mesoderm. Yeah, but there's another, like there's a specific name, يعني.
The cloaca.
Yeah, cloaca or urogenital sinus, okay? Well, mesonephric duct is for the trigon because it's from the ureters, because the ureters, they also come from the mesonephric duct, so they come and they join with this trigon as well. Okay. طيب, now we have another urethral study. طيب, let's see. Identify the labeled structures on the diagram. What's A?
Prostatic urethra.
This, yes, prostatic urethra. B,
Membranous. Yes, it's the membranous part.
Bulbar.
bulbar urethra, exactly. What about C?
Membranous.
The membranous
Membrane.
part.
Exactly. So this is prostatic, membranous, bulbar, then
Penile.
Spongy. The spongy.
or spongy. Spongy, if I'm not mistaken, it's both bulbar مع هذا. Renal. طيب, which part is at risk of being injured during urethral catheter insertion?
Venous, guess
Yeah, the
it's
membranous.
shortest and like
What surrounds it, طيب? What surrounds the membranous هنا? Does anyone remember or know? هنا, around the
Stop it.
membranous, there's something.
seminal vesicle.
No, it's a structure. It's a muscle that forms the
External sphincter.
exactly external urethral sphincter. It surrounds the membranous part.
Okay.
طيب, what's the black arrow pointing at?
The internal sphincter.
Exactly. So here we have the internal urethral sphincter, here the external urethral sphincter. So the internal urethral sphincter is innervated by what? Do you guys know? Nerve supply.
Autonomic nervous system.
Exactly. So basically sympathetic and parasympathetic. طيب, do you know what the parasympathetic does and what the sympathetic does? For this structure specifically, for this sphincter. How does it control it, يعني? What would your parasympathetic system cause your sphincter to do, the internal sphincter? And
Okay, to relax. هي شو اسمه ربي.
Exactly. Because we know in the parasympathetic, it's when you relax and digest,
Yes.
right? So it would allow you to urinate. عادي, you have
Yes.
time to urinate. So it would cause the internal sphincter to relax, allowing you to urinate. While the sympathetic, since it's fight or flight mode, it's going to cause it to constrict.
Obstruction.
So it would be contracted. Mhm.
Okay.
At rest, both the internal and external are contracted to prevent urinary incontinence, of course.
Okay.
Internal urethral, as you mentioned, it's by autonomic supply, but the external urethral is supplied by the external urethral sphincter, supplied by what?
Pudendal nerve.
Exactly, which is somatic nerve supply, meaning you have control over it. Okay, this is important. They'll probably ask you about both. Okay, inshallah, yani it's repeated and they ask you that. Yani. Okay, can anyone name the procedure shown in the image?
Suprapubic catheterization.
Exactly, and do you know when it's done? When do they do it?
enlargement صح. To see the posterior side of the bladder, yes, to check it.
Sorry.
To visualize the posterior side of the bladder.
So this is
guess.
catheterization. يعني I meant as in يعني they're trying to remove urine. So it's mainly done if they want to visualize, they would do cystoscopy يعني.
It occurs. They do it when there is an obstruction in the urethra, I guess, and the patient is not able to pee, and the bladder is distended, so you can palpate it through the abdomen, and it goes above the pubic symphysis. So the catheterization is done to empty the bladder.
Exactly, yeah. So you have two types of catheterization, urethral or suprapubic. When the urethra is damaged, as you mentioned, or it's obstructed, that's when the bladder would end up becoming distended, obviously, and they can palpate it above the pubic symphysis, and that's when they do suprapubic catheterization. But normally, your bladder should not be palpated above the suprapubic symphysis. That's why they don't usually do this procedure. The more common one is urethral catheterization. They do it a lot after surgeries and everything, because usually when you're in a surgery, your muscles are all يعني, they need time to function properly. So they do urethral catheterization. But when the urethra is damaged or obstructed, they do the suprapubic one. Okay. طيب, let's label. A. What's A? Hina, what's this?
External sphincter.
Yep. B.
Internal.
Another name. Ish, what's this part of the bladder?
Neck.
Bladder neck.
Bladder neck, exactly. C.
bladder نفس فيها شو كان اسمها؟
Trigon. من triangle trigon. على الأقل اكتب the first 3 letters يعني.
Trigon. Yeah.
Trigon. Okay. Then D. This is which
Is it
part
the
of
muscle?
the bladder? Yeah, this is, I'm talking about, this is a different part of the bladder. It's like,
The apex.
yeah. And E would be
The base.
exactly. So this is the apex, this is the base. Type. Okay, let's see. Let's label this. What's 19?
Psoas major.
Not quite.
The
So
femur.
remember, it's
Habibia?
exactly the femur. This is actually the femur. Sos major
Yeah.
is around the vertebrae. So you would see the vertebrae بالنص, you would see bone, and you would see the sos major on the both sides. Okay, it's in the middle. This is too far for it to be the sos
Okay.
major. So this is femur. طيب. Then or femoral head. What's 34? Hina. Exactly. Someone said it.
Rectum, yes.
Yeah, rectum. Okay. 36.
Uterus.
No.
The seminal vesicles.
Seminal vesicles, yes. The vast difference.
كده في lots of cysts كده أشياء زي هيك. هذه
Okay.
vesicles. طيب. 37.
The bladder.
Exactly. Okay. These kind of pictures اللي هم cross sections, honestly, the only way to memorize them is to keep looking at them. Okay. So do your best. هو إن شاء الله بس هيجي لكم 1. If you get it, you only get 1, hopefully. Okay. Oops. 21. What's 21? Aorta.
Aorta.
Okay. 22.
Where is
When-
22?
I'm trying to هنا, yeah. 22.
This. مش عارف.
We're at the top of
right suprarenal gland.
exactly. So because we're at the top of the kidney, sorry. So this would be the suprarenal gland and the right suprarenal gland, as you suggested. Type 24. Where's 24? Let's see. Yeah, 24. في عندك this كده structure جاي قدام الكدني. It's an
Tail of
anterior.
the pancreas.
Exactly, tail. You can see هنا هي spleen, and then you got tail of the pancreas. Okay.
قلنا هوا. Okay.
memorize. Just keep looking at the picture and memorize. That's the only way. You'll get the same ones, hopefully. Try to orient yourself with what's surrounding, okay? And the kidney هنا هي spleen, okay? Look at the other labelings if you have the numbers, come on for them. طيب. 29.
IVC.
وينها 29? Yeah, IVC because it's more towards the right, while aorta is more towards the middle. طيب, which vertebral level is this at?
What 34? The aorta is still. عفوا الفور ما باينه من الكدنيز. هم باينين as they said L1.
We have هنا a structure. It's a muscle.
Yeah, it's the
Diaphragm.
Yeah. So once you see the diaphragm, you'll think of what level? وعندك الأورطة that's piercing it.
T12.
T12, okay? Why? Because there's no sos major muscle. So I'm guessing at L1 you would probably see the sos major muscle. And there's presence of the right to left diaphragm cruras. Okay? مع إنه T12 و L1 are not مو بعاد من بعض, but yeah. That's what they wrote in your هذا files. Let's see. Okay, this is the last slide for me. Which zone may experience benign swelling in the prostate?
Middle part هو هذا posterior part.
Which one? Which number? Does anyone zone 2? No, it's not zone 2. ولا 1. It's zone 3. Okay. Zone 3, the transitional zone. This is the one that's more likely to swell. Okay. Then identify the structure marked by the arrow. Oops.
Is it the median lobe?
It's the remnant of the uterus in males. I think.
Yeah, pubic utricle. Yes, opening into the verumontanum, هذا, this weird structure thingy. Okay. What do you guys know what the condition is called when there's swelling of the transitional zone? It's a common
benign prostatic hyperplasia.
Exactly. Always suspected in an old man complaining of urinary urination basically. They say they have a problem urinating. They keep urinating كده شوية بيوقف. It keeps and stops يعني. That you would think the first thing you think of is BPH. Okay. And yeah, that's it for me. Now Bushra will continue. If you guys have any questions regarding my slides, feel free to email me or text me, okay?
يعطيك
Good
العافية.
luck. Good luck, guys. Allah يعافيك.
Thank you.
Bushra, I'll make you host عشان you can, I think you can share the screen. Let me just.
I'll share it out for you. Do you think we should take a slower break, like a 10-minute break first before
Yeah,
continuing?
do you guys want that? Do you prefer عشان تصلوا
Yes, please.
Okay, perfect.
Perfect, okay. Yeah.
We'll be back at 8:23, okay?
8:30.
8:23, 10 minutes.
Okay. Okay.
Bushra, we can start now if you want.
Okay, I'll start. I'll share my screen. You can see this, right?
Yes, we can see it.
All right, perfect. Okay, so let's start. Actually, this isn't evening. Good evening, everybody. This is Bushra Rasheed. I'm a fourth-year medical student, and here's my email address and phone number in case you need to contact me for any kind of questions. If you do have questions in the middle of the PowerPoint, please stop me. Feel free to just unmute your mic and convey your questions to me immediately as you have them. Okay. So this is the kidney. The way that we're going to arrange this is we're going to move downwards. So we'll start off by the kidney, by the nephron. We'll start off with the glomerulus and then move down the entire nephron. Then we'll move on to the ureters, the bladder, and then the urethra. And then the electron microscopy bit will come towards the very end. So the kidney. The kidney by nature is a lobulated structure, right? So it consists of lobes. And every lobe has its own cortex, medulla, and papilla. Now this is what a lobe looks like, okay? So this entire triangular section is a lobe. So this lobe has a cortex, it has some part of the medulla, and then it has a papilla right here. This unit is also known as a renal pyramid. Something also that's important to note here is that the cortex is very easily distinguishable from the medulla because of the differences in color and texture. But we'll talk about that in a bit. Okay, renal cortex. So if we were to take, let me turn on my laser pointer. Okay, if we were to take this cortex and actually zoom into it, this is the cross section that we would have. So the renal cortex is comprised of two main things. It's made up of cortical labyrinths and medullary rays. So the cortical labyrinth is basically, do you see like this section right here that is made up of like these balloon-like structures called corpuscles or glomeruli? This entire thing right here is the cortical labyrinth. Now the cortical labyrinth is made up of, like I said, glomeruli, but also the convoluted tubules. So the proximal convoluted and the distal convoluted tubules. As you can see here, you can see some kind of tortuous looking tubules. So that's what the cortical labyrinth is right here. And then we have the sections in between, this right here, in between two cortical labyrinths would be the medullary ray. This section right here. The medullary ray is made up of three different things. So it's made up of the pars recta of the proximal tubule, the pars recta of the distal tubule, and then the cortical collecting ducts. Now the pars recta, what that basically is the straight portion of the proximal tubule. So you know how you have the glomerulus, the Bowman's capsule, and then immediately after you have the convoluted proximal tubule. Before the convoluted proximal tubule becomes the loop of Henle, there's this straight portion for the proximal tubule as well. That is actually like people debate on what it's called, but it could be either the pars recta of the proximal tubule, or you can even call it the thick descending limb of the loop of Henle. So it's called both, but it's basically this straight portion, right? And that's what this is made up of. So it's made of the straight portion of the proximal tubule, the straight portion of the distal tubule, and then the cortical collecting ducts, which means that the collecting ducts which are specifically in the cortex. because we're in the cortex right now. And before we move on, let's also define a lobule pretty quickly. A lobule is basically one cortical labyrinth, one medullary ray, and then the associated collecting duct. All the cortical collecting ducts are going to empty into one big collecting duct at the end, and that entire structure is a lobule. So every lobule has its own collecting duct. Okay, so talking about the cortical labyrinth in a little bit more detail, the first structure that we need to focus on is the glomerular capsule. So the glomerular capsule has a parietal layer and a visceral layer. The parietal layer, which you see right here, as I'm outlining here, that is made up of simple squamous cells. You see this cell right here, it's so squashed, right? It's so squished. It's very flattened. And this is a simple squamous epithelium. It's the parietal layer of the Bowman's capsule. And then we have the visceral layer, which is podocytes. And the podocytes are actually attached on top of the glomerulus, on top of the capillaries, okay? So it would be right here. Now, on a simple H&E stain, you can't really see podocytes, but they're here. They're pretty much on top of the capillaries. And then the space you see in between is the capsular space. This is where you're going to get the filtrate that's coming out of the capillaries. All the filtrate is going to first collect here before it goes into the tubules. Okay, the second part of the cortical labyrinth would be the actual glomerulus, or the capillary bed. Now, this is made up of simple squamous epithelium. Of the capillary would be simple squamous epithelium. And another name for capillaries is endothelium, right? So the simple squamous epithelium of capillaries is endothelium. And then there's also the basement membrane of the endothelium. Now, what's super important here is the 4 different types of cells which are present in the glomerular capillary bed. This is 100% an OSPE question. This is totally coming, almost as good as confirmed. So can you guys tell me what are the 4 different types of cells within this glomerulus?
Podocytes, endothelium, so simple squamous
Yeah.
epithelium, and you have red blood cells.
Exactly, that's your type.
I forgot the last one.
Mesangial cells.
Yeah.
So exactly. So mesangial cells are responsible just for, remodeling of the podocytes and remodeling of the epithelium that's present here. It just has a supportive function, not that important, but you are supposed to know that it's actually present in the glomerulus, okay? All right. Now, the third aspect of the labyrinth would be the vascular pole of the glomerulus. The vascular pole is basically this portion right here. It's opposite. So this is the urinary pole. The Bowman's capsule is called the urinary pole. And then we have the vascular pole, which is where the capillaries are coming from, right? So the afferent arteriole would go in from here, become the capillary, the glomerulus, and then would exit from here and become the efferent arteriole. The efferent arteriole will then go on to form the peritubular capillaries, the vasa recta. We'll talk about that in a bit. It's not necessary here. But close to the vascular and urinary pole, we actually have this structure right here, this triangular thing. And this is the macula densa. Now, the macula densa is really important in regulation of sodium, in regulation of blood pressure. And so this is where it's present. It's very easily distinguishable from the surrounding tissue. I don't know. It's very easy to notice that it's right there. And then we have the urinary pole, which is the actual Bowman's capsule. The part here, the white part, where you would have the filtrate collection. And yeah, proximal tubule. Okay, let's move on. Now, now that we're done with the actual glomerulus, let's move on to the next part of the nephron, which is the proximal convoluted tubule. I want to start off by telling you guys how to differentiate between the proximal and the distal tubules. A few easy pointers to keep in mind is that the proximal tubule is fuzzy. Now, what Dr. Annie basically means by fuzzy is that there's microvilli present. That's why they look fuzzy. The distal convoluted tubule is not fuzzy because there's no microvilli. Pretty much everything else is very similar in both of them. They're both simple cuboid epithelium, along with the basement membrane, and then they're going to have peritubular capillaries around them. For providing oxygen and nutrients to the actual cells of the PCT. Because the cells that help with filtration are cells themselves, right? They need nutrition, they need food, they need nutrition to survive. themselves. So the nutrition is going to come from peritubular. As the name suggests, tubular, this is going to provide nutrition to the tubular cells. All right. The convoluted part of the proximal tubule has many circles, whereas the convoluted part of the distal tubule has fewer circles. And then, of course, the DCT actually forms the macula densa as well, and those are super packed cells. This is one example of a macula densa. This was a table that was given in your guys' PowerPoint. I think this is very pretty concise, helps you differentiate between them super easily, but there's some important points here. The other is not so much. So the fuzzy and not fuzzy, that's super important. The fact that there's microvilli present in the PCT, but not in the distal tubule, that's important. Also the difference in mitochondria, because we're gonna look at the electron microscopy bit in a second, and then that will help us differentiate between the two because of the difference in mitochondria. The fact that there's a less nucleus or more nucleus in the distal, longer and shorter. Again, histologically, the fact that these are larger or smaller is not gonna help as much to differentiate because size is obviously subjective. To me, it might be big, to you, it might be small, right? Whether it's longer or shorter, it's not gonna be as visible under microscopy, but like these are fundamental differences between them, but not as important for us to be able to differentiate between the two. Okay, right here. So as you can see right here, you can see like these really, really small structures. This is fuzz. This is the fuzziness that she was talking about, but there's not enough of it, which means that this is the distal convoluted tubule, and then there's there's so much fuzziness or so many microvilli on the top of the cells here, which means this is the proximal convoluted tubule. Also, the difference in mitochondria, as we talked about right here, there's a lot of mitochondria in the proximal, but not as many in the distal, and you can kind of see that here. The proximal cells are packed with mitochondria, but these ones are not as packed. But again, it's like if the mitochondria, you can't really differentiate based on mitochondria itself, because to me, I don't know about you guys, but I think the difference isn't that substantial. But the microvilli, you can definitely notice a difference. Okay, next we move on. So we're done with the cortical labyrinth portion, which was the glomeruli and the convoluted tubules. Now we move on to the medullary rays, which is pretty much the rest of the nephron. So these are made up of the three straight tubules and ducts. So there's the pars recta of the proximal tubule, which again, I talked to you about earlier. That's the straight portion of the proximal tubule. This is also known as the thick descending limb of the loop of Henle. The pars recta of the distal tubule, which can also be considered as the thick ascending portion of the loop of Henle. And then lastly, the cortical collecting ducts. Now the cortical, first of all, the pars recta have the same histology as the actual proximal tubule, which we talked about was, again, simple cuboid, and it's important to know that the microvilli and no microvilli difference. And then lastly, the cortical collecting ducts, there's simple cuboid epithelium once again, and then the cortical portion of the collecting ducts have light and dark cells, or the principal or intercalated cells. Okay, so this is the medulla. You have lots of loops of Henle's here. This right here would be the U-turn portion of the loop of Henle where it's getting twisted. This right here is the loop of Henle. As you can see here, these cells would be the border that would make the border of the loop of Henle. Okay, so if we were to talk about the kinds of cell in the entire loop of Henle, it's not uniform. So the thick descending limb has simple cuboid epithelium with microvilli. And this is synonymous with pars recta of the proximal tubule, which is pretty much what I explained to you guys earlier. The thin descending limb has simple squamous epithelium because of the name thin. It would have obviously a flattened kind of cell, which is squamous epithelium. Then we have the U-turn portion, which has the same epithelium, simple squamous. We have the thin ascending limb, which once again has simple squamous epithelium, once again because it's thin. And then lastly, the thick ascending limb of the loop of Henle has simple cuboid epithelium, which is synonymous with that of the pars recta of the distal tubule. Now this does not have microvilli, and then this does have microvilli because it's right next to the proximal tubule. There will be microvilli here, but there won't be microvilli in this one. And yeah, so the thick ones have simple cuboid, and then the thin ones have simple squamous. Moving on to the collecting ducts. So we have cortical collecting ducts, which we just talked about. These are the ones that are in the cortex. So the portion of the collecting ducts that's within the cortex. As you can see right here, okay? Because this is the cortex, this is the medulla. This is the cortical collecting duct, the medullary collecting duct, and then the papillary duct of Bellini. So simple cuboid epithelium, once again, yep. And then we have the light cells, we have the dark cells. Then we have the medullary collecting duct, which is once again simple cuboid epithelium. You don't have the intercalated dark cells here. And then the principal cells seem to be a little bit taller here. And then lastly, the papillary ducts of Bellini. This is where you have simple columnar epithelium. So it's not cuboidal anymore, and it does actually have microvilli. So far, the only two places that we've seen with microvilli have been the proximal convoluted tubule, including the convoluted part and the pars recta part. And then the second area was the papillary collecting ducts of Bellini. This is where you would have the tallest of the principal cells, but you don't have any intercalated or dark cells here. So the papillary duct of Bellini will drain into the papilla, and then from there it's going to be going into the minor calyx right here. So the area fibrosa is the part of the minor calyx where it's draining, and this is the first part of the entire urinary system where you're now going to have stratified or transitional epithelium. So far we've had simple squamous, we've had simple cuboidal, simple columnar even, but we haven't had any stratified epithelium. So it starts at the minor calyx, okay? Yep, the minor calyx would be right here. Okay, so in terms of the structure, once again, the first portion of the urinary system to have transitional epithelium, and actually the first portion of the urinary system to have smooth muscle. If you were to look at this diagram, the portion labeled D, these are papillary ducts of Bellini, this portion. So they're draining into the area fibrosa. This is the area fibrosa, and then all of this is the minor calyx, and then the minor calyx has transitional epithelium. And yeah, that's it. So location, yep, it's present right after the renal papilla, and function, it will allow the passage of urine to the major calyces. Okay. This is pretty much a very good summary picture for all the different types of epithelium present within a nephron. If you pretty much like memorize this one picture, I feel like you would honestly like know more than 85% of everything we've talked about so far. This one picture is summarizing almost everything. Okay, so this is the blood supply of the kidney. So we're first going to have the abdominal aorta, which is going to give us the renal artery. The abdominal aorta has 3 layers, right? So it has the tunica intima, it has the tunica media, and then it has the tunica adventitia. The tunica intima is endothelium, the tunica media is the muscular layer, and then the adventitia is just connective tissue. The renal artery is the same. Pretty much everything you see here is the same. They're all going to have 3 layers. Everything that we see here and here, all of them have 3 layers except for the capillary. So the glomerular capillary bed and then the peritubular capillaries, they're going to have a single simple squamous epithelium layer. Everything else has 3 proper layers. So the renal artery is going to give us the segmental arteries, which is going to then give us the interlobar arteries. Why is it called interlobar? Because it is in the middle of a lobe. This triangular structure would be the lobe. In between, we have the interlobar arteries, and then it would give us the arcuate arteries right here. And then at the tip, you have the interlobular arteries, right? Number 5 is interlobular vein right here. But before it turns into the vein, let's talk about what the interlobular arteries will form. Right here. Okay, so let's orient you guys once again. We have the interlobar artery, we have the arcuate artery, and then this is going to give you the interlobular artery. Okay, the interlobular artery is going to form the afferent arteriole, which goes into the glomerulus to form the glomerular capillary bed, and then the capillary bed will form the efferent arteriole, which is labeled right here. The efferent arteriole, I think I've mentioned this before, but the efferent arteriole will form the peritubular capillaries, And these are the capillaries that are responsible for the nutrition of the nephron itself, the cells of the nephron. There's no there's only exchange of nutrients to the cells. The function of these capillaries is to keep the nephron cells alive. Okay. So we have peritubular capillaries, and then they will form peritubular this entire network. And then we're gonna have the same thing, but now in the form of veins. We're gonna have interlobar vein right here. So interlobular vein, sorry. The peritubular capillaries form interlobular veins, will form the arcuate veins right here. Interlobar veins, and then segmental veins, and then lastly the renal vein. Okay, this diagram is important to keep in mind because this will most likely come in your OSPE. Just memorize the labels. And yeah. All right, so everything that we've talked about so far has been the renal pyramid, right? Everything that we've talked about has been part of this pyramid. We talked about the minor calyx right here. And then we talked about the blood supply as a whole. And now we're going to move on to the ureter. All right. So the ureter consists of three basic layers. Pretty much these three basic layers are repeated all over the urinary system, but the muscularis layer is what's different usually. The mucosa consists of transitional epithelium, which is stratified cuboid, okay? Everywhere they mention transitional epithelium, it's always going to be stratified cuboid. Next we have the lamina propria, which is fibroelastic connective tissue. Let's look at it over here. So this portion, lighter pink color, which is labeled with a T, is the transitional epithelium, okay? The part that's labeled F, the light pink part that's around this flower-like petal structure would be the fibroelastic connective tissue. This part that's labeled M, all of this is the muscularis layer, and then A all around is the adventitia. Okay, so the proximal 2/3, which is the 2/3 right here, there's inner longitudinal and outer circular muscular layer, right? And then the distal third right here, this would have three layers just like the bladder does. So the three layers of muscle just like the bladder does, okay? We'll talk about that in a bit. And then lastly, adventitia, I've already pointed it out for you guys right here. Once again, this is another example of transitional epithelium, which is stratified cuboid. Okay, moving on to the bladder. It once again has the same basic three layers of mucosa, muscularis layer, adventitia. But like the last one, we had inner longitudinal and outer circular. We now have outermost longitudinal. So it's kind of like a sandwich. Inner longitudinal, outer circular, outermost longitudinal. So in between the two longitudinal ones, you have one circular muscular layer. Talking about it on this histo image, we have, first of all, the purple looking thing, which is the transitional epithelium. Okay, this pink looking portion, all of this is the lamina propria, and then all of this is the muscular layer. Okay, this is the muscular layer. So initially we have inner longitudinal, we have this middle portion which is circular, and then outer longitudinal once again. And then the adventitia would be somewhere right here. We have rugae in the relaxed bladder, and these rugae are important because they're going to stretch out to accommodate the volume of urine once the bladder is full. Okay. Yeah, so basically a relaxed or a distended bladder pretty much looks identical. It has the same number of layers, right? Every time you need to urinate, the number of layers can't change. But what can change is the structure of the epithelium. So as you see here, the structure of the epithelium, it's very dome-shaped transitional shape. Right here, and they're binucleated. So this is one cell has two nuclei. This one cell also has two nuclei. Once the bladder is full of urine, this is going to stretch. So these cells, which are now looking very round and plump, are going to stretch to accommodate the volume of urine. All the rugae are going to straighten out so that the urine can be accommodated. And so the transitional epithelium actually changes shape here in the bladder. Okay, so the trigone of the bladder. It is smooth triangular region at the base of the bladder. It has three different orifices. So these two are ureteric orifices. This is where, as you can see, the ureter right here. This is where the ureter would enter at the back of the bladder. There's no sphincters here, but there are valves here. And those are very, very important to make sure that there's no backflow of urine into the ureters and then the kidney. And then lastly, we have the urethral orifice, which does have a sphincter, and that's known as the internal urethral sphincter, pretty much at the neck of the bladder. So the function, it's sensitive to stretch. So the trigon, since it is smooth muscle, it is very sensitive to stretch. And so the moment there's enough urine in the bladder and the trigon area stretches, it sends signals to the brain to make you conscious of the fact that you have a full bladder and that you need to empty it. And then the other function is ureteral valve functioning. Of course, this area is so important in making sure that there's no vesico-ureteral reflex. There's no urine that's going back up. Location at the bladder. Okay, so the male urethra is divided into 3 portions. We have the prostatic urethra. This is the last place in the entire urinary system you're going to see transitional epithelium. Right here, this is 1. Membranous urethra, which is stratified columnar, right here. And then penile or spongy urethra, which is the one that's right here. Both of these are stratified columnar. Once the penile urethra ends, the external urethral orifice begins. And this is basically where you're going to have, so towards the inside of the orifice, you're going to have non-keratinized stratified squamous cells. And then once the cells go more towards the periphery, or they're beginning to come towards the external environment, they're going to become stratified squamous keratinized. This is really interesting because there's 3 different kinds of cells, all in the urethra alone. So you have transitional in the beginning, which is stratified cuboid. We have stratified columnar in the other portions of the urethra, and right at the end of the urethra, you have non-keratinized squamous and also, also keratinized squamous cells. Male sphincters, so there's 2 types. There's the internal urethral sphincter at the neck of the bladder. This is the involuntary one, which is controlled by the autonomic nervous system. And then we have the external urethral sphincter, which is within the pelvic floor, and it's controlled by the somatic nervous system. It's controlled consciously, you're in conscious control of the this bladder. The female urethra, okay. So you know how we talked about the male urethra, how the urethra is divided into 3 portions? That's only because it's so long. But then we talked about the types of cells and the transition of cells from one type to the next. The female urethra, the first half is transitional, just like the male urethra, and then the second half is stratified columnar epithelium. This is very similar to the male urethra, but it's just the male urethra is not divided like half and half the way the female is. So that's the epithelium. Moving on to the lamina propria. Once again, it's fibroelastic, nothing different about it. Muscular layer, inner longitudinal, outer circular, so 2 layers, not 3. And then we have the adventitia connective tissue. Function for the female urethra, transport urine from the bladder to the external opening. Female sphincter, pretty much the same, but the internal urethral sphincter doesn't function as well as the male internal urethral sphincter. So there's only one proper urethral sphincter in females, but there's 2 proper ones in the males. Okay, we're nearing the end of the PowerPoint. So let's talk about the electron microscopy. Okay, so first we'll talk about these cells. We'll look at what are these different types of cells, and then we'll talk about their function. So the first one we have right here, it does not have any kind of microvilli, and there's absolutely no mitochondria in the cells. What do you guys think this could be?
A principal cell.
A principal cell, exactly, perfect. So this is where, that's right, could you give me 1 minute, please? Okay, sorry. Sorry. So you're right, this is the principal cell, and then this is present in the collecting duct. Okay, perfect. Then we have this cell right here. We actually looked at this earlier. There's very, very few microvilli at the tops of this one, and there's mitochondria present as well, but they're not abundant. What cell is this?
Distal collecting duct.
A distal convolute. Perfect. Thank you. Then we have these cells right here. You can see the abundance of foot processes here, and podocytes on top. So what do you guys think this is? Glomerulus. Thank you. Moving on to number 4. What do you guys think this is? Oh, this is the bladder. This is pretty much the bladder. Number 5, would anybody like to answer what that is?
Loop of Henle.
Loop of Henle, perfect. So this is, do you think this is the thin loop of Henle or the thick portion of the loop of Henle?
Thin, because it has only one layer.
One there, that's perfect, thank you. And then lastly, we have number 6. We can see the abundance of microvilli. And there's so many mitochondria. What kind of cell do you think this is? PCT. All right, that's totally right. If this is part of the proximal convoluted tubule. Now let's talk about these questions at the top. These two, there's a very, very high probability of these coming in your OSPE. So counter current multiplier. Out of all these 6 cells, which ones are going to be related to the counter current multiplier system?
5.
Number 5. Let's see if you're right. What I can. Okay, you're right. Awesome. Let's move on to the next one. Which one of these is responsible for filtration? Just good old filtration. Number 3. Perfect. Thank you. So number 3 is the glomerulus. Sodium and water reabsorption specifically. So when they talk about this, they don't want reabsorption of anything else, just sodium and water. Number 1, that is right. And then which one of these is responsible for reabsorption? Number 6, reabsorption. Yep, so that's the proximal convoluted tubule, urine storage, and stops urine leakage because of the tight junctions. Number 4, yep, the bladder. And then lastly, we have secretion. Only one of these is left. Number 4, absolutely. Number 4, wait. No, sorry, number 2. Yeah, sorry, I looked at the chat and I got confused. You're right, number 2. And that's because if you look at the arrow, this one is going towards, so this is where the microvilli are, right? And the microvilli are towards the lumen, of course, the lumen of the tubules. And so if this is going inwards, this is most likely secretion. So from the blood, it's going into the urine. Versus this, because it's moving against the microvilli, this means that it's getting reabsorbed into the blood. This is where the blood is, and this is where the urine would be. And so this is reabsorption. All right, so this is our last slide pretty much. This talks about the different types of layers that are important within the exchange mechanism, the filtration mechanism. So the first layer we have is right here. E stands for endothelium. These are cells of the endothelial capillary. F is the fenestration. Now, when you look at F, it's really important to know that there are no diaphragms here. This F is without a diaphragm. Why is this important? Because there's another F that has a diaphragm, which we'll talk about in a bit, okay? So we have the endothelium right here, and these are the endothelial cells, simple squamous epithelium. Then the basement membrane, half of this basement membrane is for the endothelium, and then the other half is for the Bowman's capsule. Their endotheliums have fused together. And then these last P2 and P1 are podocytes. These are the foot processes of the podocytes, and there's very small junctions right here, and there's a diaphragm in between. And all of these mechanisms are, first of all, the foot processes, the slits, and then there being diaphragms in the middle are because they want to, our body, the kidneys want to make sure that unnecessary products don't get filtered across the membrane, things like proteins, albumin. We don't want these big molecules to be filtered across. And so that's why the slits are so small. And then there's even a diaphragm in the middle. Yep, so this side was the Bowman's capsule slide. This was the blood, or the glomerular side. P1 and P2, there's two different types of podocytes. P1 has larger feet and P2 has smaller feet. So, and the space in between the feet is the slits, the filtration slits. And that's pretty much it. That's it. Thank you so much for staying with us. If you guys have any questions at all, please feel free to email either me or Rawan, either one of us, and we would be happy to help you. And yeah, these are alternative resources. I used some videos to help me make the slides for you guys. And if you're interested, I can share these on the chat if you want to go through them. Give me 1 second. There you go. These are 2 different videos for renal histology. And I hope that it helps you. You're welcome, guys. I'm really, really happy to have helped. If you have any questions, again, please feel free to contact me. And that's it. That's pretty much the entirety of the PowerPoint. Thank you guys for coming, and best of luck for your exam.